Hello, everybody. This is Christoph Röllig. I'm a consultant hematologist at the University Hospital in Dresden in Germany. And I'm happy to give you a short introduction or glimpse at the study result that I was able to present at this year's annual meeting of the American Society of Hematology. So I was asked, or basically you can put the content of the study that I was presenting in a nutshell by asking, can we omit a second induction cycle in patients with good early response? And in order to answer that question, we came up with the following study design. We set up a clinical trial that was called Daunodouble. In that clinical trial, we tried to answer two important questions from everyday clinical care of AML patients, newly diagnosed and eligible for intensive treatment. So these patients will normally be treated with some sort of flavor or variation of DA or 3+7 or 7+3. So basically a combination of standard dose cytarabine and an anthracycline, cytarabine over 7 days, anthracycline over 3 days. A couple of decades ago, the so-called double induction was established in Europe as a way of standardized intensification, irrespective of the results of the first induction cycle. For all patients, a second induction cycle would be started from day 21 of the first induction as a kind of flat regimen or flat strategy. And the question we tried to answer with the second part of the Daunodouble trial was whether patients with a good response at early bone marrow assessment after induction 1 would actually need or benefit from a second induction, or whether we could spare a second induction for patients with a good response after the first induction. So what we did is all patients received a standard 7+3 induction. We assessed the response in the bone marrow on day 15, and for all patients with less than 5% blasts on this early marrow assessment, those patients were defined as good responders, and they were randomized. One half receiving a second induction and the other half having the chance to recover their blood counts without a second induction. The primary endpoint of the trial was a complete remission rate. So we compared whether, or we estimated whether CR rates would be higher after double induction or not. And obviously, secondary endpoints were survival endpoints and also tolerability. In order to answer that question, we were able to randomize 270 patients with a good response after the first induction. When we did that, we saw that a good response was achieved in about 45% of all patients undergoing a first induction. So around 45% of patients had less than 5% blasts. And 133 were randomized to receive no further induction, and 137 patients were randomized to receive a second induction. And when we compared in the per protocol population, so patients who actually were treated as randomized, the CR rates at the end of induction, we have a CR rate of 91.4% after double induction and 88.2% after single induction. So the CR rates differ only by 3%, which is clinically not relevant anyway. But if we look at this from a statistical point of view, our assumption at the beginning was that single induction was non-inferior to double induction, and the pre-selected or the preset non-inferiority margin was 7.5%. And here we had actually 3.2% difference only. However, from a formal statistical point of view, this data, because of the rather wide confidence interval, did not prove non-inferiority yet. However, this is an interim analysis, and we are still keeping on including and randomizing patients. So we hope to be able to come up with more reliable and consistent results after we have finished the trial, which will be done by the by the middle of next year. If we look at other outcomes, such as relapse-free survival and overall survival, we saw a small difference of 10% benefit in relapse-free survival after 3 years for patients after double induction versus patients after single induction. However, that difference was not statistically significant, and our follow-up is still limited. If we look at overall survival, we see that this relapse-free survival difference does not translate into an overall survival difference, because overall survival after 3 years was completely identical between these two study arms and was 74 to 75% after 3 years. So in conclusion, we can say that based on these results, it seems that in patients with a good response after one standard induction cycle, 7+3, with a good response, meaning less than 5% at early bone marrow assessment, these patients seem not to benefit from a second induction cycle. We hope to be able to prove that with a statistical high reliability once we have finished the trial, but it all looks as if we can omit a second cycle of induction in patients with a good response after the first induction. At least if these patients, if we consider these patients kind of borderline eligible for a second induction cycle. And I hope that we will be able to give or provide a more definite statement and result by next ASH meeting or after the final analysis of this trial. And with that, I thank you for your attention, and I would also like to thank all our patients and the collaborators of the Study Alliance Leukemia Study Group in Germany who actually did this trial, and the physicians and trial sites who documented the results and treated the patients. And thank you very much for your attention.